The next person is Dr. Gaurav Luthra, who's another expert with us from Dehradun. Gaurav, can you talk to us on it?
Sure.
Can we switch off these lights here? These floodlights? ये भी बंद कर दो यार.
Okay.
Thank you.
Thank you so much. Good morning, everyone, and it's a pleasure to be here in Vizag. And thank you so much, Dr. Amar sir, for considering me for this important session, which I am really privileged to be part of. It's one of the biggest running courses in ESCRS and ESCRS and the academy, with no place to stand inside most often. That's what I get to see, and they have to stop people outside from coming in. So I thought I'll share a couple of different situations with you. This was one really black-brown cataract that we were going to operate. And this patient had also a little bit of zonular dehiscence, and he was having unhealthy capsule as well. So we started off. This was, I think, a vitrectomized eye, so there was likely to be more challenges with the capsular integrity. So as we were trying to crack this, the patient suddenly moved, as you saw there. I don't know if you picked that up. Let me just take you back. You know, as I was completing my first crack over there, I saw suddenly that I'm embedding, I'm chopping, and suddenly the patient moved big time as I was completing the crack. Here. And I didn't realize at that time what might have happened, but let's go on and see. Also, the pupil, as you can see, is coming down. It's become a floppy iris. Some of the iris is tending to come out from my side port. I'm trying my best to create a lateral separation and crack the posterior plate. And I managed to get some of the endonucleus out. I like to do this for my hard cataracts. So here I'm now putting back viscoelastic. I've put in phenocaine. I'm doing everything that can be done to keep this going. One thought was to go in and put iris hooks, but I realized that I may be able to, since my chops were already complete, I'm trying to see if I can get the nucleus fragments out. And you can see that you have to be extremely careful that your phaco tip never goes anywhere close to the pupil or the iris, because you'll immediately catch it, because you're using high settings of vacuum and flow. But once you've actually cracked the posterior plate, it becomes much easier. Now once I've got this out, I feel that my situation is now much better. You can see how floppy the iris is, but the moment I come out, the PC almost literally comes forward and bulges and touches the cornea. And now you can see that I'm stuck with a smaller pupil with a lot of sticky cortex, which is literally kind of pasted to the capsular bag. I'm trying to get that out. I go in with some more phenocaine. You can see that patient is quite uncooperative, moving around as well. So that's adding to the whole fun of trying to do something for this patient. But anyway, using all the skills, inflating the bag with viscoelastic, making sure that it's nicely inflated. At this point, I wanted to put in a CTR, but I was suspicious that there may be a capsular excess break when that patient had moved at that point. And there was a situation where I thought that I can just get this cortex out. Also, I was worried that if once I put in the CTR, it will be almost impossible to get this cortex, which is already stuck in the equator of the bag. I didn't want it to become more complicated, so I decided I'll go on till I can, and then when it becomes, you can see how it's bulging forward. So now again, I deepen the chamber with viscoelastic, and at some point now I'll have to put in a CTR. You can see how lax the bag is. So I take the call, and this is what they always say. You have to put in the capsular tension ring as late as you can and as early as you must. So this is when I needed it now, because the bag was beginning to come in. With every time I was going in, the bag was coming back. So you can see it's a very, very floppy capsular bag as well, in addition to the iris. But with a lot of patience, I was able to do that, and see, in spite of the CTR in situ, you can see that the bag is bulging forward almost all the way to the cornea. And then finally, I can put in a lens. So I was able to save this stay, and as Dr. Amar likes to say, paradise regained, because now you have the lens in the bag, and there goes. So this was one situation, and I'll quickly go on to a second one where I struggled for no reason, and this has a lot of take-home messages. So this was presented in Bob Osher's symposium this year at ESCRS. So this was again a black-brown cataract with some zonular laxity. we had done a femto assisted procedure that gives you a little bit of confidence with the getting the perfect rhexis size, a bigger rhexis, and some nucleotomy as well, and that helps. So once this was done, we went ahead and I was going to proceed with like a routine patient, made my side ports. I don't like to make femto side ports, but I do like to make LRIs for correcting astigmatism. The capsulotomy usually is one of the stronger points of femto procedures because, and also the nucleotomies that have been done. So a hard brown cataract, but see it's much easier to cleave it because along the cleavage planes, so becomes little easier to handle, and you can see that now I've managed to bring out the cataract and just washing out some of the cortex. I'll finish with this case, I think one more minute. So you can see again that the capsule is bulging forward and a lot of bulge there. I'm now going ahead and it seems to be a straightforward case. There is cortex which is sticky and I'm getting it out. You can also see here that my view is a little obstructed by this little strand of mucus or something on the cornea. I wash it away several times, but it tends to just find its way back. And now I'm removing that cortex there, and now there goes. What happens is that in my hurry to finish it off, and maybe because of this poor view of this mucus strand, which you should always remove with maybe a Johnson's bud or something if it's not getting washed away, I pull the bag. So I'll just show you how I pull the bag. So I'm just going there, and here I produce a big zonular dehiscence. So now I'm in a situation and I'll have to do something about it. I keep the infusion on, disengage, I do a reflux and make sure that I'm not holding on to the capsule. And once I've freed the capsule and the cortex from my aspiration port, I switch on the infusion and I decide that now I have to do something. I'll have to go back, put in viscoelastic. I come out, but just see I've again made a mistake here. I have not put in visco before switching off the infusion. The bag is moving away, and now a third mistake. I'm quickly going in to put viscoelastic. I go from the side port thinking that I'll just form the chamber quickly because the capsule is moving southwards. I put in visco and just see what's happened. Now half the bag is here. The bag is crumpled up because the visco pushed it away further. I should have come from the other side port, or I should have come from the main port and inflated the bag itself inside the rhexis rather than from just the side port. In my rush to put in viscoelastic, I did not put my cannula all the way inside, and I just did this. So lots of mistakes there and lots of lessons to be learned. Now I'm going from the other side port. My assistant is trying to find a cannula which will go in from the side port, a narrower cannula, because this is a standard supplied visco cannula with the syringes. I would use the 23 gauge cannula here. So now I'm finding the better cannula. I'm checking whether my bag and rhexis is intact. And once I do that, I will go and inflate the bag with a finer cannula. So you should always have this ready just in case you have to inflate the bag from the rhexis itself at the rhexis. So now once I've done this, now things will become much easier. But at this point, I decide I have to put in a CTR. Now the direction of CTR always has to be good, but just see how I'm going to struggle. Lots of mistakes and lots of learning points here. I'm trying to figure out which will be the best direction so that I don't increase my zonular dehiscence. I think I've found the right plane, but as I go there, now just see what's happening. It's again increasing the zonular dehiscence. So I've tried 3 directions already. None of the directions is working. And then I go from the side port, and I think that maybe from this side port I will get a better situation. But again, I have to abort it because it's not going the correct way. And then I have to find the correct situation. So now I'm going from the third side port and making sure, guiding it in, and somehow making sure that it does not increase the zonular dehiscence. So this was a bad day in the OR, and finally I was able to get the CTR in and finish the case, and this looks good in the end. So finally I'm checking whether everything is good. My CTR has gone in and I'm getting the lens in. Then on the MIOCT I checked whether there was any IOL tilt. I found that there was none. Everything looked good, and then finally I'm going to be able to get this complete. So you can see more challenges on the way. The lens was not going into the bag and the bag is loose. So anyway, everything was good. One capsular hook was required, and I'll finish here because I think we have 2 more speakers. I'll finish. I have more cases, but I think we have not enough time.